myself and start with my presentation. So my name is Janine Lanz. I'm a social worker and supervisor, and I have been working in the field for more than 20 years now. Seems like a long time, but sometimes it doesn't feel like that anyway. Of which I have coordinated and worked at a supervised consumption facility for the last 14 years. So I'm still partly working in the field. The majority of time I have other things to do anyways. So I'm going to share my screen, and I hope it works. Can you see my screen?
Yes.
Very good. So, okay. So as you could tell, I'm not a digital native. I'll do my best not to get lost in that. So I'm going to talk about the contact and drop-in centres and supervised consumption facilities in the city of Zurich. I'm not going to dive too much into the history, as we've already heard some of it in the morning, like about the drug policy and how we came to have introduced the 4-pillar or maybe 3-pillar drug policy. Exactly, but still, I'll tell a little bit about about the history. Like we go a little bit down the memory lane because we've experienced the misery in the 90s, myself, not as a professional at the time, but as a young teenager living in the city of Zurich. It was very present at the time. And we've heard that this morning too from somebody that our parents were very aware of the fact that we could go there and that would be very harmful. So I can very well remember how it looked like around the train station there. I think, as I said already, we heard about the times there. I still think it's very important that we are aware of what has been achieved in those days, and we kind of that we really acknowledge it and value it a lot, because we still kind of relax on the achievements from the 90s and the early 20s. We have a very comfortable situation in Switzerland and in the city of Zurich. So just shortly, I don't go too much into the slides here, but we go to the 4-pillar drug policy, and on which base it became possible to legally open supervised consumption facilities in several cities of Zurich. As you already know, it's like prevention, treatment, law enforcement, and harm reduction. I don't have the concept of the 3 pillars yet, but I'm going to be thinking about it anyway. So we still have the same objectives as back in the 90s, actually. So especially from a from like the community point of view, like the compliance with our environment, not abstinence, that's our point of view anyway, but from the community, from the society's point of view, it's the relief of the public space, the maintenance of the public order. From our point of view, like from our perspective as professionals, it's more our goal is more to get the people off the street, to get in contact with the users, to build relationships upon we can support them, upon we can gain the right to intervene with their lives, with their circumstances. So the relationships we have with our clients are actually the base on what we can work with them and support them. So, I have 2 screens. That's why I lost you somewhere on the slides. Excuse me about that. So for us, that's the integration of drug users. I'd say about 90 up to 95% of the people who come to our centres on a regular basis, we have known for several years and therefore know pretty well. And last, very important, is the cooperation and coordination between social work and police services and medical assistance services, especially the cooperation with law enforcement is crucial for the success of a supervised consumption facility, because at the end of the day, we've got similar goals. We want to have the people off the streets. We want to maintain, as I said before, public order, even though, again, from a different perspective, still, it's crucial that both sides, or all of us, understand how important our services are and how important it is to maintain what we have nowadays, and even go further in our work. Today, like at this day, we have 3 supervised consumption facilities in the city of Zurich. During the first year of the pandemic, we only had 2 of them. We operated only 2 of them. Since May this year, we have 3 again. You can see the facts and figures here. So we have about 950 regular users, about 200,000 syringes per year. And this is, we have way more inhaled consumption than injected consumptions. So it's 1/3 to 2/3 actually. And it's the average of 27,000 users of illegal substances per month. And it's very surprising for us, or kind of surprising, that before the pandemic, it was 22,000 users of illegal substances per month. So the numbers have increased about 5,000. And we tried to figure out how come. And one thing we can tell is that we have, over the last 2 years, an increase of about 70 users. Part of them we haven't known before. The different facilities have overlapping opening hours. So from morning 7:30 till the evening at 9:30, a facility is open. After 9:30 and overnight, especially the homeless people can go into an emergency shelter for the night, where they are allowed to use illegal substances too. So even if you're homeless, you don't need to go out in the street to use. Which I think is very important. So we have a 24-hour system actually, but the drug consumption rooms, the supervised consumption facilities, are only open during the days towards the evening. So now I come actually to the challenges from the last 2 years. Because the pandemic changed quite a lot. In February 2020, we started to get an idea that it wouldn't work out the way we used to work. And I actually have to go one step back. I was a little bit too quick. I just want to tell you first, before we go into our special situation, to the services, which haven't changed a lot over the years and are still well needed. We still obtain drug consumption rooms set up for supervising hygienic use of pre-obtained drugs, injecting smoking, inhalation, or sniffing of drugs. The smoking and inhalation has increased a lot over the years. So nowadays, at the moment, we have 18 places for us for inhalation, and only 7 for injecting. We have meeting place and shelter, recreational activities, not so much at the moment due to COVID-19, and medical counseling and health promotion, first aid and doctor's consultation on site. So as well, we have a needle exchange and supply of syringes and needles, information and counseling, personal single case work and triage, and laundries, showers, clothes exchange, which is used daily, especially in winter times when it's getting colder and unfriendly outside. And we do have work opportunities where people can cook or work the bar or do some cleaning, all kinds of things. So back to what I started before, and I lost track a little. We did get an idea that it wouldn't work in our cramped infrastructures. We have like quite a tight space in our former locations, so we knew we couldn't keep that up. We would have to do something about it, and we were well, there were quite common sense about that. We definitely wanted to keep up our services even in a lockdown, because we wanted to prevent the open drug scene, and we wanted to provide shelter and a protected place for our clients. And I mean, the all over mantra was like, stay at home, which is actually quite difficult when you're homeless. So there were some voices who said, you've got to close everything down, but where would our clients have gone if they would have done so? So creativity and innovational spirit was needed, and we actually had that. Actually, Florian Mayer came up with a great idea to use the place normally dedicated to the sex workers as a temporary open air consumption facility. And as prostitution was prohibited at a pretty early point in the pandemic, the place was free. So we moved there in a matter of very few hours and days. Actually, in a matter of 2 days, we moved everything over to that space, and we turned those boxes that normally are used for sexual services into consumption rooms. So we had 2 smokers rooms and 2 injecting rooms, and we worked there for about 2 months open air, all the teams thrown together, and tried to, it was kind of freestyle. Sometimes it was like an open air feeling, because we had a tin barrel with a fire because it was pretty cold in March. And we had a grill. People would barbecue their sausages. Some people played guitar. Some had their beers. It was kind of very, very different from everything we've known. But we did know it wouldn't last forever. So we started to plan a return to the city centre. So we needed approvals, and they were obtained pretty quickly due to the special conditions. So we were allowed, for example, to set up a big tent in front of Kaserne, one of the bigger facilities in the city centre. In Sellnau, walls were installed, so you could divide the rooms into several smaller rooms. Yes, so what you see here is the pop-up facility. That's a huge tent. We've got 18 spaces here, the ones I mentioned for the smokers. This is the recreational area. You see those pallets, it's pretty fancy. We just worked there, built that all up, and gained a lot of space that way. So we could manage to have about 70 people at the time in the facility. We still have that, actually. We're still working with the tent, and that works very well. What we have learned from that is that space really does create de-escalation, because people can avoid each other's. They don't have to bump into each other. So we had less violent escalations during this time. But then on the other hand, space can also lead to people going under. So especially individuals can remain anonymous for longer, and that way, especially when new people we don't know come along, it makes it more difficult to make relationships work with them. What we have learned too is that controlling the scene by controlling the offer, like the micro deal, we really had and have to allow the micro deal in the facilities. We did so at the temporary consumption room, and we do too in our consumption rooms, which is discussed with the police too, so we're on safe ground there. Well, the division of the scene is not possible, and offers must meet demand. Like we really need to watch out what is needed. What do we need to do? What offers do we have to provide? So it's altogether been a very, very interesting and very intense time. We're still in it, actually. So just shortly, because I run out of time, the challenges we have had before and we're still having to meet in future is the increasing need for long-term care at a relatively young age. And we see that in our facilities, that in infrastructural problems we have, we're not barrier-free. So we have more people in wheelchairs. So we would carry them up the stairs and carry them down the stairs again. And I think that's that must change in the future. Then severe mental impairment, dual diagnoses such as schizophrenia, depression, and post-traumatic stress disorders. Those two at the moment are not as acute. So what are issues too is a partial lack of willingness to cooperate for all office. We have some clients in the city, and you would know that from your cities too, whom we can't reach. Nobody sort of can. They fall through the net work of helpers. Increasingly aggressive social behavior, and for us, as we really try to keep the people in our facilities for as long as we can, because we really want to keep in contact with them, but at a certain point we have to exclude them because they disturb the whole environment, and partly strong and socially disintegrated people. The young clientele with partly intensive criminal history, we try to get in contact with a special offer who's working on the especially on those issues with them. So I mean, you might know, like harm reduction prevented a lot of numbers, like from nearly 16,000 new HIV infections. I'm not going to go through all the numbers. I think and firmly believe that it's very important that we keep on doing what we are doing, that we keep on being innovative, awake, and open-minded, and don't forget about the importance of our services. So I thank you for your attention. And you can join our Facebook group if you'd like. That would be nice. So we're coming back, Leah and Elisabeth. I just want to welcome you.
Thank you.
Dr. Elisabeth Avril from Paris. She is the executive manager of Gaia organizations and volunteer for the NGO Médecins du Monde in Georgia and Armenia. I'm really looking forward to hear about the current challenge of DCR in Paris. I've heard a bit last week in Prague already during the session, so I'm looking forward to hearing more. Thank you. So the screen is yours, Elisabeth.
Thank you very much for the invitation, and I tried to make it quick. And on this picture, you can see our DCR with the injecting booth, and on the left, you have the smoking area. And it's the only DCR in Paris, and we have only 2 in France. So it's I wanted just to go back very quickly on the history of this DCR, because it took us 7 years to launch the project, and many stop and go from the authorities and politicians. And at the end, we had to wait 2 more years for the modernization of public health law. And we had this DCR for 6 years of experimentation. So it was in 2016. So now we are waiting for something, because the experimentation is nearly over. Just to talk about my organization, we have also for a long time now, for nearly 25 years, we have an addiction center with OST program, low threshold OST program with a fixed point on a bus. And we have also a dropping with fixed point on bus, a DCR. And also we have a screening HIV, HCV, HBV mobile unit who is going on all the Paris region. And we have also a professional reintegration center called Labo Fabrique, and other things like we tried with a partnership with Aurore, it's another organization, to create a new dropping and a new DCR in 2019, but we failed. At this time we failed. But I'm going to explain why. So our DCR, you can see the smoking room, with 6 booths, but we did some change, but I have no new pictures. The injection room and the restroom, and it's open now from 9:30 a.m. to 8:30. At the beginning, it was only open in the afternoon, and we have 12 booths of injection and 6 booths of inhalation, and we have a team of around 40 employees for the DCR, for the outreach work, for the mobile unit, and now for the team for the hotel. Because since the beginning of the epidemic, we have a new team to go to the hotel where we shelter the people. And during the COVID, we closed the smoking room, and it is still closed now, not really because we can't open, because we vaccinate a lot of our clients, but because of the political situation. I will go on with that. So, well, the DCR, it's like other DCR, the only maybe the speciality is we developed many services focused on care, because we had a lot of questions. It was so difficult to get this DCR. Authorities are asking us a lot of things in a medical area, like so we have psychiatric consultation, medical consultation, referring to substitution treatment, and also blood-borne virus screening, HCV treatment inside the DCR, and now we are doing vaccination and also for the COVID. The activity since the beginning until June 2021, we have 1,500-600 people enrolled since the opening, and we had a total visit of nearly 300,000 visits. And I think I can't see my screen. I have, because I don't know all. We had, yes, 220,000 injection and 36,000 inhalation. And also to see, we have medical consultation. Does it work, this thing? I think it's blocked. I don't know why. My screen is blocked. Oh, so we had 560 medical consultation, and I took the our report of 2019, because in 2020 it dropped down because of the COVID. We had less professional, and we closed something like social consultation, and we focus on sheltering the people. And we had few, not so much monitoring after drug use, and no deaths occur in the DCR. I think it worked. The specialty in Paris is to be the only DCR for a region of 12 million inhabitants. So it leads to an important activity. And the other specialty is that there is no more heroin in the street. So especially for precarious drug users, so they inject mainly legal drugs. Has the big, you can see scanner, it's morphine, in fact. It's tablets of morphine. And they inject also quite a lot of methadone, and Subutex is buprenorphine, and also they inject crack. And this is really a specialty. We have less than 3% of heroin in the DCR. So we have less overdose, because with the morphine sulfate, drug users, they know how they can inject every day, so there is no mistakes. The current situation in Paris, I wanted to talk about that. We have a highly politicized context with the municipality election in 2020, and now we have the presidential election coming soon in 2021. So it blocks a bit all the thing. And we had the major morphine injection scene since 2005 in the Gare du Nord sector, and to which the DCR responds. And we have a National Research Institute who did deliver its report on last May on the 2 French DCR, and the results are positives in terms of decreased HIV, HCV risk practice, decreased abscess, decreased emergency rooms visit, decreased delinquency. So I think all these positive results should have led the government to open other drug consumption rooms, but no, they decide the contrary, because we have a big crack scene also in the north of Paris. Since 1994, we had the installation of drug users in squat or industrial place, wasteland since 2004. And the crack user population increased since 2010. And we have an estimated population of 7,000 to 10,000 people. And all these people are generally polyconsumer, morphine, crack, alcohol, benzodiazepine, and they have a big social disaffiliation. And the crack scene settled in the northeast of Paris since many years. And now the crack is the first drug consumed, with a main increase these 5 past years. And we can see a willingness of the organization to open new DCR and integrating center, but because of the complex political situation, the projects are blocked now. And the only response of the authorities is to move people when the tensions are too high with residents, when the residents are demonstrating every week, and when there are violence towards a drug user, they move them to another place. And also the French government does not agree within it. We have a Minister of Interior who is really against the process of new DCR. He blocked blocked a new DCR in Lille, the big town of the north of France, 2 weeks ago. And while the Minister of Health pushes for new DCR. I wanted to show you the crack scene in Paris. You can see on the left, the police moving all the people. They put them in buses. They put the users. They put the dealers, and they move them to where there is this big tree. And they are just now in this statement. And before they move them in a park, and after they close the park, and they were all just in front of the park, as you can see. I think it reminds you the picture we saw on the last presentation with Janine on the Splat Splits 30 years ago. But now we are in 2021, and it's a pity. And in November 2019, we were ready to open a new DCR near the scene, but the police moved the people. There are around 150, 200 people to another place, and the authorities did not allow the opening. And the population gathered not so far, but was moved again in January 2020. And they gather in a place called Stalingrad Square, where it's a place where we have a lot of people, new people coming, how do you say that, gentrification. So they couldn't stand to have all these drug users just in front of them. And in June, last June, as the cafe and restaurant reopened after the lockdown, police pushed the drug user with the municipality agreement in a park nearby, with the message that consumption will be permitted. And in 1 month, the population increased to 200, 300 people. And the neighbors demonstrated every week. So in September, 2 months ago, police moved them by bus and to another open space near Paris Ring Road. And in October, one young girl died on the scene, the first died. And now we are in this, I show you how they move them from one place to another every time. And this is the last 2 years, but this story lasts for 20 years now. And so our perspective, we did a coalition with other harm reduction organizations, and we came together to bring this issue to the Prime Minister. And we have written letters, and we are asking for a date and for a pragmatic strategy that means the needs of the drug user in the region. And more precisely, we asked for a new crack strategy, which would develop venues or place of rest, care, and consumption. And we also need to improve collaboration with hospital and the psychiatric sectors because we have really difficulties to work with them. And we have, as said Janine, we have also a lot of drug users with mental health disease, and they have no treatment, and then they have no follow-up. And we try to continue and strengthen collaboration with the state service to limit the street consumption and the large gathering of users. But in conclusion, we should do more public health and less politics, but we are not really heard by the authorities. And even if we have the main mediatic questions on newspaper, now on television, radio, newspaper, it's the crack scene of Paris. And it's quite incredible because it's only 200 people. And the question is, can DCR solve the drug scene in Paris? Because all the people, because it's election, they want to force them to detox. and they say that it's the only solution is to force them to detox. And the neighbors are not really helping us because they confuse the consumption room and the consumption scene, and they don't see the difference between. And we are really quite desperate this time not to solve this problem, and not even one step ahead. We are blocked in a really bad situation. Well, thank you for your attention, and I'm there for the questions after.
Thank you so much, Elisabeth. That was very, very interesting, and seems to be a lot of work ahead of you, and a lot of energy you need to work in that field.
Yes, because we need to speak to the neighbors, and they are quite harsh, and also the political, the police, and the newspaper, the media, and at the end we have the day are long.
Yeah, and you have so much resistance on all fronts, actually. Yes, thanks a lot for sharing.
Thanks.
So, Rasmus Koberg. I don't know whether if I pronounce your name correctly, who is a candidate from the University of Roskilde in Denmark, and the manager of 2 drug consumption rooms, Skien and age 17 in DCR Copenhagen. He will share his experience with a 24-hour DCR in Copenhagen, pros and cons. I'm very interested in that too, because that's kind of a discussion that's coming, like a subject that's coming up every now and then. So the screen is yours, Rasmus. Thank you.
Yeah, thank you very much, and thank you for having me. And do you hear me? Can you hear me?
Yes.
Great. Yeah, my name is Rasmus, and I have been working with drug consumption room for almost 10 years here in Copenhagen. And for the last 5 years, we have had some experiences with what we could call 24-hour services. It's not like it is 24-hour services, because we are cleaning in the middle of the day. So we are open from 1 o'clock in the afternoon to 11 o'clock the next day, and then we clean up for 2 hours. So it's not 24 hours, but it's 22 hours. Just to give you a little insight about the situation in Copenhagen. Vesterbro, a part of Copenhagen, close to the central station, has been the open drug scene for almost 50 years. It's very centralized. It's area in about 1 square kilometer, so it's like 5 blocks in each direction, and we have between 500 and 600 individual users a day coming to this area. Some of them are here for a very short time, some are here longer, and some of them are here all the time. We were in Denmark a little late with drug consumption room. We got the first drug consumption room in 2012 in this area, Vesterbro. And we did that actually because of a pressure, and it's interesting to hear Elisabeth talking about the neighborhood demonstration, but it was actually the opposite way in Copenhagen, that the neighborhoods actually pressed the politicians to make drug consumption room, because they saw drug consumption room as a part of the solution, because at that time you could say the whole area was one big public drug consumption room. So in that matter, we were more lucky than they are in Paris, that we actually had the neighborhood behind us in doing drug consumption room. Right now we have 2 drug consumption rooms in the area. I'm talking about in Vesterbro. We have an area with a smoking room where we have 20 seats and 10 seats for injection. And then we have a smaller room with 8 seats for injection and 8 seats for smoking. So in totally, then we have to count. It's about 28 seats for smoking and 18 seats for injection when when the whole operation is open. The small room is not open 22 hours. It's open 15 hours a day. So in 15 hours a day, and also during while we clean up in the big room, we also still have a possibility for the users who can take drugs. After we had opened for some years, there was actually a pressure also from the neighborhood that they were actually, most of them were happy about the drug consumption room, but they said that there were still, drug users are also taking drugs at night. And in Copenhagen, cocaine has a very, very big it's the biggest drug. About 70% of the drugs that are been taken in the drug consumption rooms here have something to do with cocaine, either pure cocaine or the ball with cocaine and heroin. So cocaine is a very, very big factor. And when you take cocaine on a regular basis, you sometimes don't sleep at night. And sometimes you don't sleep in many nights. So there was this DCRs that were open until 11, 12 at night. But what did the user do after the drug consumption room closed? And what they did was that they were doing drugs in the streets like they did before the drug consumption rooms. And of course, this is a very, you could say, populated area. A lot of people are living here. And of course, when you have drug activities at night, the neighborhood will be disturbed about that. So the neighbors actually said that the politicians should give some money so the DCRs also could be open at night. So we started out in 2015 in our small room and got some experience with the night open there. It quite soon we find out that it was not just a walk in the park to have drug consumption rooms in the night. I think many of our conflicts and stuff like that was during the night, and it was rather what could you say? It was not easy to get it going in the beginning, but suddenly we got more experienced staff and we dealt with the problem there was. Then we have had actually for the last 5 years we have had a 22-hour drug consumption room open, and if we should see a little on the pros and the cons about having drug consumption room in the night, you could say that of course all this disturbance in the neighborhood and all this screaming and shouting and drug intakes in the streets and stuff like that are more or less gone, and many of the drug intakes are located to the drug consumption rooms. We are talking about sessions, so we have a day session, we have a night session, an evening session and a night session. And we can see that the night session is from 3 o'clock in the evening, 3 o'clock in the afternoon to 11 o'clock in the evening. That is the time schedule where we have the most intakes. But the second biggest period is actually in the night, and the daytime is actually the period where there are lessest drug intakes in our drug consumption rooms. So it gives a lot of meaning actually to also if you have a drug environment, a drug area, a drug community who are very happy about cocaine, drug consumption room 24-hour services are are actually a very good thing. Then during the pandemic, like in Paris, the authority closed down our smoking rooms, and they didn't close down our injection facilities, but they, lesser people could get in at the time, and actually also a lot of the users disappeared from the area because they were scared of COVID. And we had also a period where many of our employees and the users were infected, and we had actually from the 23rd of December to the 23rd of January, we had 18 full-time staff members who were sick of COVID, and we had 35 of the users who also got COVID. So we had a lot of problems with having the office open at all because everybody was sick, and if they wasn't sick, they couldn't be on job because they have been in close contact with people who were sick, and all that things we all tried last winter. So we had some periods where we closed down, and we also saw that when the facilities are closed, some people are going home. And I think if we are talking a little about what is not good with 24-hour services, is that you maybe what you could call a little like a Las Vegas feeling, that it's always open. Why should we go home when the office is always open? And it's not like so maybe when we close down, some of our users will go home and get some sleep, but still also during the pandemic we also saw that maybe some are going home, but there are also some who are staying and who are doing drugs in the streets and stuff like that. So, but you could, if you are against 24 hours, it could be an argument that, yes, if it's open all the time, why should you ever go home? So that could be a discussion point. One of the, we are in our two services, we have about 20,000 intakes a month. That is about 660 intakes a day. And it's half injection and half smoking. In Copenhagen, it's almost 50-50 smoking and injection. But cocaine is a big factor both for the injection and for the smoking population. Another very good thing about having a 24-hour service is that we have a pretty big offer here in H17, and we also have a room where people can sleep. So you can actually both do your drugs, but you can also sleep. And every night we have more than 20 people who actually are sleeping. And when you have a drug environment where cocaine is a very big issue, sleep is the perfect medicine. We like when our users are sleeping. So the long opening hours also do that a lot of our users actually get some sleep. So that is also a pro. But it was an experience for us during the pandemic when we closed down and to see what happened in the environment. And I don't think it not only have to do with the closing of the smoking room. It also have to do that a lot of our users were very, very scared of COVID and didn't want to get affected, so they find other places to stay. So it's maybe, but it was a calmer environment in a period also when the DCRs were, you know, not closed but almost closed, and that was interesting. A lot of our we have about 2 overdose situation a week in the drug consumption room in Copenhagen, and actually almost 35% of them are in the nighttime. So that's also you could say a pro of having drug consumption room open in the night. So there in Copenhagen, you know, the drug users are doing drugs 24 hours a day, also during the night, and we are proud that we also have a service for the night drug users. Thank you.
Thank you, Rasmus, for your speech. You mentioned a few very interesting points, actually, that sounded quite familiar to me too, and we maybe will have time later on to discuss. Thank you. So I welcome our last speaker, who is Larissa Maier. She's got a huge CV, so I'm only gonna introduce her shortly. She's got a PhD in addiction research and works at the University of San Francisco in the Department of Chemical Pharmacy. She'll be talking about the opiate epidemic in the US and the challenges of opening a DCR. I'm very looking forward to hearing from you, Larissa.
Thanks so much.
It's yours.
Thanks so much for the invite to everyone and for the nice introduction, Janine. And just to slightly correct you, I was working at the University of California, San Francisco for 3.5 years. That's where I did my postdoc. And I actually just finished that position in September. And with that, I'm also sharing my screen. And start from here. I'm really happy to also provide a little bit of a broader overview after we heard from Switzerland, Paris, and also Copenhagen, all the cities that I really like and have been quite a bit. So right now I'm gonna dive into the US, but I'm actually sitting in Switzerland and at this very moment, and before coming here, I had a brief stop in Oaxaca, in Mexico, where I also visited Oaxaca City, and there the tradition of Dia de los Muertos is a really beautiful one, where people honor the people who passed away by actually having an altar and adding some drinks and food that the people like. So it's a really beautiful tradition. And there I was thinking about the people I lost in my life. And before I went to the US, I was like, I lost my 2 grandpas and 1 friend from childhood. But I'm really privileged and lucky that I didn't lose more people. But then I was like, wait a minute, I moved to the US and there I had friends, and I actually lost 3 of my friends in San Francisco over the course of these 3.5 years related to overdose that involved drugs. As you can see, it's Sean, it's Kate, it's Tim, and all these people were young people. They were celebrating with us. They were very positive, and whether it was intentional or not in different cases, there still is like a narrative that is now much closer to me than it has been before my US stay. And when we look at what's happening in the US, this is a media news from yesterday, actually, from the New York Times, that shows us that last year during the pandemic, when we were on lockdown from April 2020 to April 2021, we lost more than 100,000 people to a drug-related overdose. And this again involves opioids, but not just opioids. A lot of people have polysubstance use, and especially stimulants are also very cheap. We see that except like from the 50 states, except 4 states, in all the states, the drug-related overdoses have increased over the past few years, and especially from during the pandemic. And we've seen the highest increases in Vermont, West Virginia, and Kentucky. These are also states that are known to have somewhat conservative views, and we have to say that even within states that are liberal or considered liberal, such as California, where I live, we have 50 different counties, and they are handling cannabis legalization differently, and they also react very differently with regard to overdose prevention and what they provide. So in the United States overall, we've seen that there is like a progress when we look at harm reduction, because for the first time this year in April, when they announced under the new administration the drug policy priorities, we could see that enhancing evidence-based harm reduction efforts is part of the policy. How exactly that will be implemented was not quite clear, and of course there's a lot of political things that are happening in the US and re-election and other things that dive into it. But it's also the first time that we see that advancing racial equity is part of these priorities. And that is important to notice, because people in America, like the whole war on drugs was really a racist war against Black people and people of color, who would disproportionately more frequently use crack cocaine, which until today has a higher like a higher sentencing practice compared to cocaine powder. And that is also, that was like lowered, but it's still not the same. And obviously powder cocaine was used more by white people. And currently at the federal level, we have the Equal Act that also tries to get away with that and really equalize sentencing as well. Obviously, youth substance use is in the center, and a lot is around recovery support. We don't have to forget that the United States for a long time have followed an approach, and still a lot of people believe that abstinence only is a right approach to pursue. And we see at the international level, for example, at the United Nations Office on Drugs and Crime, when they meet for the Commission on Narcotic Drugs each year in March, that this year it was virtually and online. That was my 5th time attending. We saw that for the first time, again, the United States in their statement also mentioned harm reduction. And harm reduction is very common language for us, but it's still not agreed language at the UN level. This is why it's very important. Even though we want to improve harm reduction efforts, we don't have any supervised consumption site in the US as of 2021. And there is only one study published on a site that is unsanctioned, like kind of a hidden site in one of the cities. Some of you may guess or know where it is. But most importantly, like with all the other studies that we have about overdose prevention sites, we see that there are no overdose deaths reported. And we also see that in the opioid overdoses over the years, we saw a slight increase of overdoses occurring at the site, and that is directly linked to the increase of fentanyl in the street supply. In San Francisco and in other cities, we have seen that since 2010, fentanyl is more and more in the drug supply. And as of today, it's the drug of choice for many people. We also have a study, because a lot of people talked about substances and supervised consumption sites. So one of them has looked at what is needed in the United States to actually implement such a site. And one point we often forget, because it's like so natural, and in Switzerland it was really top down, like we needed to do something and it was established and people kind of were flowing with it, is to include people who use drugs. I know that Avril is also having a priority on that and is discussing it, but I don't think it's very present for us in Switzerland, or maybe also in other European countries. But people who use drugs need to be involved at all stages of the planning and the design and the implementation of these services, for these services to be successful. Diverse partnerships can help with all the local stakeholders, and we also need to be aware that sometimes it involves a lot of work to support allies, like other projects around housing, that they actually help and stand up in the city hall again when you come up with your initiatives. Lobbying policymakers is clear, and I think some of the barriers that are also put out in this study are really to define the location, where should it be, and how to interact with state and federal legislators, because there we still don't have a law at the federal level. Currently it says we're violating federal law because of the crack house statute. If we are allowing substance use of any kind of an illicit substance in our houses when we know it. We also need to look at gender and race and all these issues, and we need to tailor the interventions to these people to make sure it is really used by those people we want to reach. And obviously it's always difficult to identify a funding source, but one case that you've heard is Safe House in Philadelphia. So they really had all the support together. They even identified a location, but then another court kind of stopped them, and they tried to bring it to the Supreme Court. And as you can see, in October last month, the Supreme Court said, like, we won't hear their petition. So this is now also going back to the US, like to the general attorney, and he will have to deal with it. And that again looks into how the Biden administration is like actually dealing with these things. Different societies have taken a stance on supervised consumption sites, and American Society for Addiction Medicine has kind of pushed on something that already was said by the by the Society for Medicine. And they said that the federal, state, and local government should take action to ensure that state and locality sanctioned pilots of overdose prevention sites can operate without fear of prosecution. Because that's actually the moment we've heard it in Switzerland too, back in the 90s, where people were fearing to lose their license to practice when they were having a relationship with these sites. More and more, we're talking about it in the United States, it's in the media, it's in the news, but I just want to point out with these two studies that the acceptability of such sites, for example, in San Francisco, has already been proven more than 10 years back. And again, like so many studies, we're looking at how we could implement it. And this is in particular important for San Francisco, where I've been living for 3.5 years, because there are a lot of people who are unhoused. They are not the only people who are using opiates or heroin and fentanyl and other drugs, but a lot of the people who are unhoused deal with comorbidities of substance use and mental health issues. And that's most visible because they're obviously on the street and no supervised consumption rooms are there. That's kind of logical. Again, it's very important to acknowledge that polysubstance use is common. And as you can see, the overdose deaths in San Francisco have increased to more than 700 last year. And just to put it in perspective, like, it's such a small group who is at risk of overdose, but at the same time, we had about 250 people who died from COVID in San Francisco, and everyone was potentially at risk to get COVID and die, right? So this is the actual thing. And as you can see, the overdoses are increasing. We count about 57 people per month at the moment. So this would lead to, again, more than 700 people dying from a drug-related overdose in San Francisco this year, despite having a lot of programs available. And in this map, you see that it's very centered. So a lot of the overdose deaths are really located in the Tenderloin or in Soma, which is south of Market. And that's also where I moved in for the final month of my stay, just to be closer to the people who use drugs and talk to the people on the streets. At the same time, I was following all the meetings of the San Francisco street level drug dealing task force. So they had about 15 meetings to come up with solutions. And obviously supervised consumption rooms are one of the solutions, but some of the solutions are also a bit more conservative, or they think that by having like marketing or like announcements about fentanyl and that this should not be provided, they could actually help with the overdoses too, which is not quite where we're going. But as you can see, there was a really big spike with the police incidents related to drug use and open air drug dealing, especially when the pandemic started, but also otherwise. So it's an up and down, it's not going away. And people who use drugs in San Francisco also know where to go. And I'm also said to the task force, as long as you don't have an open air dealing zone, like for example, Christiania in Copenhagen, where people can go and get their drugs, and as long as this is not existent and we don't provide a safe supply, there will always be such a drug market and an open air dealing in San Francisco. Importantly, we see that a lot of people are reversing overdoses, and that's mainly also due to the drug overdose prevention and education project. They trained so many people and they've been helping with the overdoses. And if you think that this was just like 1/3 of the city, you can calculate, and you know that last year more than 10,000 overdoses were reversed, where people didn't die, following the use of naloxone here provided as Narcan, as a nasal spray. And there are also injections that are given to the people who use drugs, so they can immediately reverse overdoses of the other peers that are using substances. So at the At the syringe access program where I was volunteering prior to the pandemic, we were handing out Narcan also in form of needles. San Francisco had a really good start. When I moved there, I was really excited because they just opened a model project, Safer Inside. That's the mayor on the left side that you see, London Breach. She was already there kind of in support of supervised consumption sites. It was clear something needed to be done. People have discussed it by 10 years. But then the former governor vetoed that bill that would have allowed the sites. So people were really disappointed. It was at the end of August. I was right at Burning Man and I came back. I was really happy. But then this was really a downer to see. And we have a history of governors. The current governor is probably in support, but it's not currently on the table. But he just last month vetoed another bill which would have allowed contingency management for people with methamphetamine use disorder to be kind of paid by the insurance system. So that was vetoed because he thought he would rather wait to see, because the pilot project is about to start and he doesn't want to say yes before he sees the result of that evaluation. We know it from Zurich, from other places. Data drives policy, and sometimes we need to move forward and we don't have the right data at hand. And it's oftentimes very difficult to actually get to the efficacy of these projects when so many components and factors are involved. So I was personally working with Senator Scott Wiener to actually move forward these overdose prevention programs, but the bill is, as I told you already, again on hold. Other states have progressed, and in July, the governor of Rhode Island has actually signed a bill into law that will create a program for harm reduction centers where people can also consume their drugs under medical supervision. So that was almost kind of the first kind of its things in the United States. But we've also seen that, for example, in New York, that's an article of last month as well. The mayor has worked on supervised consumption sites for a long time, and in his final term, he now tries to push forward. The next day, he already says, we don't really have a plan right now. And we also have a really good commissioner, a health commissioner there in New York that is really pushing for overdose prevention centers because so many people are dying, and he knows that it will save lives and connect people to critical services. In San Francisco, again, around the world, we have more than 100 sites. We talked about Europe. In San Francisco, since last year, since ever, we have this support. The Board of Supervisors also supported it. And now, yes, 2 days ago in the newspaper, I could read that San Francisco is again trying to open these sites by spring. And we have to see that a lot of money is going into overdose prevention. And again, we still have more than 700 people dying. And a new project that has started this year is the street overdose response team. When people call 911 for an overdose, they will be redirected to that team so that people with a social work or psychologist background are reaching out instead of the police. Another center that was really pushed through, and I've been at all of the meetings, and it was really hard with the neighbors to come to an agreement, is a Soma Rice Center, again, south of Market, where we will have 30 beds 24/7 for people who are experiencing challenging moments under the influence of methamphetamine or other drugs. And in Zurich, obviously, Janine already showed it to us, there were certain developments during the pandemic that I also want to highlight and that I shared in the space also in San Francisco and at the US Capitol, where I've also been advocating for change. And this is in particular important because I also recommended it for the World Drug Report, where I contributed to a booklet 5 this year, where we looked at COVID-19 and the impact on drugs and drug use. So there was a supply side part and the demand side part, and I've contributed to that part. And I can also say that if you look at the references on the bottom, you will find 54 references dating to harm reduction papers that were actually citing harm reduction in the paper. And again, in the article or in the booklet, it's not mentioned exactly as harm reduction because that's not agreed language, but it's in there and you can find it. There were a lot of changes. Here you can see me with Kim Soo, who's like one of the doctors from New York who's really pushing for overdose prevention and access to supplies. That was prior to the pandemic. And again, during the pandemic, we had some things that came up, that we had more telemedicine or prescriptions of buprenorphine and methadone via or mainly buprenorphine via online counseling. There was more contactless distribution and mobile sites to actually reach the people who use drugs, especially when they were unhoused. And we also had more of opioid agonist therapy medications, just like here, and that has been a success. The UN report concludes that there is obviously, with all these vulnerabilities, maybe more drug use. So I agree, we don't get away with that topic, which is why it's important to look into the future and come up with solutions. And here in 2020, we had more than 170 overdose deaths in British Columbia, and people were handing out like cocaine that is, as you can see, not as pure as the cocaine we test here in the drug checking services in Zurich, but still it contains no fentanyl, and people can make an informed decision on how to use it. A second point I want to raise is really, we talked about youth substance use and how regulations should just provide access to substances for people who are like who are adults. And I think we shouldn't forget that a lot of people start using drugs when they're young, so that youth voices always are considered. And that's a picture from the Commission on Narcotic Drugs meeting last year, because we were in the first week of March, still in Vienna, before that pandemic was declared. And the third point, which was not mentioned today in the whole situation or in the whole symposium, and I really just want to touch on it very briefly, is that there is also a future in looking into psychedelics and their value for recovery. On this picture, you see David Smith, who is the founder of the Haight-Ashbury free clinic in the 60s, when the hippies needed medical care and the government said no. He just did it. And I was hosting the meetings with the Psychedelic and Entheogen Academic Council at UCSF over the pandemic. On Zoom, we had like 58 meetings, and David got inspired because the room where we're standing in is provided or zoned as a retail space, so we can sell books about psychedelics there. Both he and his wife recovered from opioid addiction when using psychedelics. And there are many projects and studies on the way that will show beneficial effects of ayahuasca and other substances such as ibogaine for certain types of people with addictions. Now, it's not for everyone, and we need to be very careful there. I'm happy to provide more information otherwise, but this is the center that is just about to start. And with that, I just want to conclude that, again, we need more data in many ways. We're also currently recruiting data for the Global Drug Survey. We have more than 900,000 people and hope to get a little bit more. And the only thing we need to do, that is my goodbye in San Francisco at Twin Peaks at sunrise, is to provide safe spaces for people to explore and interact with each other. And it is like a responsibility of each organizer to handle that, but especially when we have people who are unhoused, it is a necessity to have supervised consumption rooms where people can find information and eventually also triage to treatment if that's a desire that they would pursue, and otherwise just have a safe space to be and really put the focus on the people who use drugs. So the people need to be at the center, and I thank you very much for your attention as the very final presentation of today.
That great presentation. That was a lot of information we got from you, and it would be so interesting to have a lot of time to discuss. But we have nearly run out of time. We have 7 minutes to go for questions and answers. So to speed that a little up, you were advised to ask your questions via the chat function, but I would suggest that as we are only 21 people in the room, that we might ask the questions directly. So just unmute your mic. Other than me, usually. Unmute your mic and ask your questions to whomever you want to ask it.
I had one question for Rasmus.
Mm-hmm.
It's on the. I understood you had 3 sessions: day session, evening, and night, and that the evening session from 8 p.m. or 6 p.m. to 11 p.m. is the session where you have the most incidents and problems. That
intakes. Most busy hour is from 3 o'clock to 11 o'clock.
Okay, 3 o'clock p.m.
Yeah, in the afternoon.
Yes.
Yeah, that is the most. But nights are the second busiest session. You could say. Yeah.
That we can see also in Paris from 4 p.m. to the closing time, 8:30, because we have no more time. But it's a question in Paris to say, if you want. Some people say okay for DCR, but then you will have to open them 24 hours because at night people are doing drugs and they have nowhere to go.
But where, Elisabeth, where are your users when you're closing down? Where are they going? What are they doing?
During the COVID, we shelter 440 people, and they are still shelter in hotel. So some are going to the hotel, but the other they are going where I show you the sort of square garden and going around or going in this Stalingrad place. They are just wandering here and buying drugs and doing drugs in the street. Not next to our DCR, they are moving to another part of the town. Because usually I go at night in this garden and I see the guys have seen in the DCR. So they are.
Elisabeth, we were together this summer in Strasbourg.
Yes.
Nice to see you again.
Yes.
And at the same day we were together, they made this park deportation, or the deportation to the park. Are the users still in the park, or are they into the center again, or what is happening right now?
As I told you in my presentation, but maybe it was too quick, they put them in, they closed the park because there were so many people. So during 1 month, they were just in front of the park on a short pavement. It was awful. And then they came with buses and they put everybody in the bus, dealer and everybody, and they moved them to Porte de la Villette. It's near the Ring Road. So now they are in this place. It's a sort of a big garden, not between two big roads, between the Ring Road and another road. And they are there is nothing. And when they try to make some tent or some township, three times a week, municipality services come and destroy everything that they are not going to settle. And we propose to settle some place just to help the people, and they say no. And now they talk about a big bus that we could make medical consultation in the bus. But in fact, they are trying to they pretend they are doing things because it's a political, the election next year. So they are pretending that they are going to do, but they are doing nothing. Because the mayor of Paris, Madame Hidalgo, she's running for the presidential election. And so they are just like, it's political fight. And it's easy to talk about drug users, these people very precarious, and there's talk about crack, and they don't want to see that the main problem is the poorness of these people and the racial problem also, because most of them are Black people, and they don't want to see that. So they just move them and say that they will move them again if the residents are going up. No solution. At this time, we just have to wait until the March next year. After the presidential election, maybe we will be able to do something, but I'm not sure, because the political, the public opinion, and they are all talking about. I'm really worried about the the discourse saying that you have to lock them down, lock them in some place, we don't know where, but lock them and detox them and do that and do this, and against harm reduction, saying, look, harm reduction does not work because you have all this crack scene, and the crack scene has been done by the police and the politician. It's
scary.
Thank you very much. I'm sorry I have to interrupt here because it's 5 o'clock. We're actually run out of time. If there is one last question, this would be the time to ask.
May I ask a question?
Yes, of course.
Thanks. Hi, my name is Adrian Corman. I run the heroin-assisted treatment in Zug in Switzerland. And before I worked for Avril, and I was consultant of the National Board of Health in Denmark between 2010 and 14 when you introduced heroin-assisted treatment. So my question is to Rasmus. Do you have more, a higher number now for heroin addicted treatment patients than you had then? Because politically it was limited to 120 people, I think, and which is not a high number actually in comparison to Switzerland. So this is my question. And thank you all for the very good workshop.
I'm not an expert into the heroin treatment. I don't know the exact numbers for it's not quite on my field, but it's still there. I don't know the numbers. There are clinics in Copenhagen, outside Copenhagen, and also in other parts of Denmark. It's pretty integrated, but the numbers, I don't know. One of the problems was that you almost have to live on the clinic to get your heroin. And if you were working or stuff like that, it was impossible. So so they were very, very scared of give the heroin, give the clients the heroin with them home and stuff like that. They have to inject it at the site, and they have to stay there for 2 hours before and 2 hours after and stuff like that. So that was a problem for many users, but I don't know it but I know it on a personal level because we also have clients here who are into heroin treatment, but it has not become a very big thing in Denmark like it is in other countries. But I'm not an expert.
At least you have some. We don't have.
Yeah. Hopefully you will be able to get some really. I thank you very much, like the people in the workshop for their attention, the speakers for their presentations. It was a pleasure sharing this session with you. And I would just like to wrap it up and wish you a great evening. Hopefully we'll meet one day at the conference or wherever. And yeah, we hope all the best to you.
Thank you. Bye-bye.
Bye.
Bye-bye.
Thank you very much.
Bye.
Bye.
Are you okay, Elisabeth?
Yes.